try to review lung cancer. We've enabled this Lung Cancer 2015 Nursing Review. This is for those of you taking the OCN certification, and this is kind of a review over lung cancer to sort of help you with this. What we're going to try to do today is we're going to try to review a little bit of the anatomy of the lung and to give us some insight into how it impacts lung cancer. Then we're going to talk about some of the nuts and bolts of lung cancer itself, how we treat it, and then some of the nursing implications. So we'll try to cover the outline that is in your OCN book for lung cancer and see if this might help with your nursing review with a little bit of our own comments. So the epidemiology of lung cancer is the second most common cancer in both men and women. Prostate is the most common in men, and probably breast cancer is the most common in women, and then of course colon cancer is the third most common. So it's a very, very prominent cancer that we see every day in our practice. As you can see, 14% of the total cases in the United States in both genders are made up of lung cancer, but 27% of all cancer deaths are lung cancer. So not only is it a common cancer, but it's a very deadly cancer because a lot of people unfortunately die of their disease, and our chances of being able to cure lung cancer are really not good. Getting better, but not good. The incidence is slowly decreasing due to decreased smoking, because smoking is clearly the leading reason for lung cancer, and the whole history of smoking is very interesting. For those of you that know that people came back from WW1 and WW2, the men came back smoking, and about 20 to 25 years after that, there was a high spike in lung cancer in men. And then in the late 50s and early 60s, women started smoking more, and there was a huge incidence in lung cancer in women in the late 70s and early 80s. And now there's a high incidence in both genders because of smoking. So smoking is very, very important, and now that we've understood what smoking means to us from a health point of view, and there's certainly almost a social stigma against smoking, a lot of people have stopped smoking, and the incidence is slowly decreasing from that. So maybe in another 20 to 30 years, we'll talk about lung cancer being a lot less common. Unfortunately, and what we see in Memphis, this is certainly true from the data we know from our own work here in Memphis, but poorer outcomes and a diagnosis at a more advanced stage is very common in African Americans. And that is a reflection mostly of the social economic situation of the African Americans in our community, more so than any genetic kind of traits, because they just don't seek care as well, and they usually have more comorbidities once they get lung cancer, and we'll talk about the importance of comorbidities in the treatment of lung cancer. Pathophysiology, the lungs are located in the chest, and they have a role of air exchange and filtering of microparticles. That's very important because obviously the lungs are so you can breathe, but it's the exchange of the smoke inside the lungs that causes the problem, because the smoke carries the carcinogens and brings it back into the lungs, and it also brings microparticles into the lungs, which can be important for other causes of lung cancer other than smoking itself. The anatomy is that the trachea leads to the bronchi and then to smaller bronchioles, and end in alveoli where the actual air exchange takes place. There is an extensive blood vessel system with an extremely large surface area. Excuse me. This is very important because that's what gives us our tremendous reserve in our lung capacity. And what I mean by that is you really have to do a lot of abuse to your lungs before you get short of breath, because the machine we have that the Lord gave us to begin with has a huge reserve built up into it. And that's because of this extensive blood vessel system. So there's a lot of surface area where the oxygen and carbon dioxide exchange can take place. So there's a lot of damage that can take place before you really become symptomatic from a shortness of breath point of view. The lungs are separated into lobes. There's 3 on the right and 2 on the left. So when we have somebody that has a mass in their lungs, especially if they're smokers, we automatically start thinking about this being a lung cancer. And so we start doing things to try to analyze and look at why they might have, what this diagnosis might be. So a lot of times here in the clinic, for example, we are sent patients with masses in their lungs that have not even been diagnosed yet, because people see a mass in the lung, see a smoker, and they automatically think it's lung cancer, and they send it to us. So when we try to do this, what we have to do is we have to work up the patient to find out what the diagnosis is. So the first thing we do, obviously, is get a complete history and physical. This history and physical really needs to be pretty extensive. We need to know what their comorbidities are. We look for things like diabetes and hypertension and coronary artery disease, peripheral vascular disease. A lot of these are the result of their smoking themselves. And then we also want to know what their smoking history is or any other exposures they might have, because there are other elements in the environment that can lead to lung cancer. We want to know that from their history and physical as well. But their physical is very important too, because we want to look for things like weight loss, what kind of shape they're in overall, because that can really tell us how well they're going to tolerate the treatment and tell us right away what their risk is from their lung cancer. That's the word for that we use is called their performance status, and that puts kind of their whole picture together. What can they do, and how is their body capable of doing it? So performance status is very important. Then we look at their laboratory to see what's going on. A lot of times people with lung cancer will have a chronic anemia because they're chronically ill, either from the comorbidities they've had before or from the tumor itself. They also can have some abnormalities in their electrolytes. They can have increased bicarb because they could be retaining CO2 because they have COPD from their smoking. They could have a decreased sodium because they have a syndrome of inappropriate ADH. So there's a lot of things we can get from the laboratory itself. And then we need to know what their pulmonary status is. These are pulmonary function tests. We need to know what their pulmonary function tests are, especially if we're considering surgery, because remember we talked about the fact that the lungs normally have great reserve, but after you've been smoking 20 years, that reserve has been eaten up, and if we take away part of your lung surgically, we may make you what's called a pulmonary cripple. Fortunately, we don't have this happen very often, but sometimes we'll finish these surgeries, get the lung cancer out, and the person is virtually oxygen dependent the rest of their lives because they don't have enough lung to give them enough oxygen CO2 exchange. So pulmonary status is critically important. And then we look at imaging as well, because we want to know, just as we tell our patients every day, when you have a diagnosis of cancer, you want to know, first of all, is it cancer? Then you want to know what kind of cancer. And then you want to know how much cancer there is so you can know how to treat it. So that's what the imaging tells us. The CAT scans initially tell us that, yes, there is a mass and it is suspicious, but remember, a CAT scan is an image. It is not a diagnosis. So we can't tell somebody they have a diagnosis of cancer till we get a biopsy to prove it. But the image can be highly suggestive of the cancer. And so when we see that, that's usually when the patient is sent to us. And so what happens at that time is we go ahead and then we get a PET scan, which is part of the staging process. Remember, a PET scan is more appropriately called a PET CAT scan, because we inject radioactive sugar in them that develops a hot spot at the hypermetabolic areas, which is also where the cancer is. And as a result, and then we also follow that at the same time with a CAT scan to tell us where the hot spots are. So it gives us a stage of the presumed cancer. And unfortunately, in about 30% of the cases, over the history of their disease, patients can have brain metastases from lung cancer. So we always check an MRI of their brain to make sure that their brain's not involved. And this can often be asymptomatic. So we get this without whether they have symptoms or not. When they do this, or when we do investigate the brain, we want to make sure that they don't have any metastatic disease there, because that obviously changes their treatment a lot. And about 10% of the time, we will see patients that will present with seizures or symptoms of a stroke, and what happens is the brain metastasis has caused them to have the seizure or caused them to have the stroke-like symptoms, and they didn't even know that they had a lung cancer, and they present with these brain symptoms, and it really is from their metastatic lung cancer. At the same time, we do a biopsy and a molecular analysis The biopsy is where we actually get tissue to find out what kind of cancer it is. And first of all, to find out if it's cancer at all, and then to find out what kind of cancer it is. Once we know what kind of cancer it is, and we'll talk about the histologies in a little bit, we can decide on the treatment. But at the same time, specifically with lung cancer, we will send off a molecular analysis, which means that we send off some of that tissue from the cancer, from the tumor itself. We send it off to a special laboratory that evaluates the DNA and the genetic material inside those cancer cells. The reason we do that is because there are specific mutations that we now have medicines that we can treat to reverse those mutations and sometimes get their cancers to respond to this mutational manipulation. And it's very important that we identify those. It also gives us some ideas about other kinds of agents they might actually respond to, and we'll talk more about this at the end of the talk when we talk about the new immune therapy in lung cancer. So that's kind of how we start off. We find out the patient has a mass, we investigate how much tumor they have, what kind of tumor it is, and then we think about staging. The staging is based on the TNM system. TNM stands for tumor, nodes, and metastasis. So in lung cancer, what tumor means is we just measure the tumor. And the larger the tumor is, the higher it is. So there are four stages of the T part of the staging system, depending on the size of the tumor. The larger the tumor, the higher the T stage is. Then we also want to know the nodal status. That's what N stands for. And so there are a number of different ways to think about the nodes. For example, if there are nodes right around the tumor itself, that's N1. If there are nodes in the hilum, which is the lower part, which is the central part of the lung itself, that would be N2. And if they're extensive in that area, it'd be N3. And then we look for metastatic disease itself. That's what the M stands for. Metastatic disease in lung cancer usually means anything outside of the chest. So, but there is an M1 classification if you have a lesion of cancer in the other lung. That doesn't happen very often, but it does happen enough that that can be seen. And if that's seen, that's considered metastatic disease as well. As you can see from the next bullet point, stage 1, 2, and 3 are all within the chest, and stage 4 is distant metastasis or in the contralateral lung, as we just talked about. That's really the important differential in the treatment of lung cancer because stage 1 and 2 are potentially surgical. Stage 3 is still theoretically potentially curable because it's still in the chest, but it would require combined modality with chemotherapy and radiation therapy. But stage 4 is considered incurable, and we'll talk about how people present with that in just a little bit. There are two major types of lung cancer that we talk about, non-small cell lung cancer and small cell lung cancer. The reason we divide it up like that is because small cell lung cancer is different than non-small cell lung cancer in the way that it spreads and the way that it grows. It tends to spread very early in the history of the disease, and small cell lung cancer will often present with metastatic disease. So small cell lung cancer initially only had two stages: limited, which meant it was in the lung itself or in the chest cavity itself, and extensive, which means it was outside of the chest cavity. However, the newest idea is to put it under the TNM classification as well, but I'm not sure how well this will catch on because this is a brand new system and a lot of people still use the limited and extensive staging. We'll talk more about non-small cell lung cancer when we talk about the histology itself, which we're going to talk about now. So we talked about non-small cell lung cancer, which we abbreviate NSCLC. There are three types of non-small cell lung cancer: squamous carcinoma, adenocarcinoma, and large cell carcinoma. These three cancers are similar in the cell of origin and are similar in the way they grow and similar in the way they act, but they're really very similar in the way they respond. The chemotherapy we use for these three tumors are very similar, Adenocarcinoma has some different chemotherapy, which we'll talk a little bit about. But most of the time, these three tumors are treated pretty much the same way, so that's why they're classified as non-small cell lung cancer. Small cell lung cancer, as we talked about, tends to grow more rapidly, tends to spread early in the history of the disease. It many times will be a big bulky tumor in the center of the chest with a lot of lymph nodes involved at the initial presentation. Many times you'll have paraneoplastic syndromes with small cell lung cancer, because small cell lung cancer, the cell of derivation is really a neuroendocrine cell. And neuroendocrine cells are different than the cell of origin for the squamous, adeno, and large cell. The cell of origin for those three lung cancers are more usually the cells that line the bronchi themselves, and the small cell lung cancer cells are neuroendocrine cells that are all over the body, but are particularly vulnerable to become cancer in the lung. There are other types of lung cancer that are much less frequent. There are other kinds of neuroendocrine tumors other than small cell carcinoma. Carcinoid tumor itself is a well-differentiated neuroendocrine tumor. And then there's the cancer that's associated with asbestos exposure, mesothelioma. Mesothelioma is important because it is so intimately involved with asbestosis, and from a practical point of view, a social point of view, there is a large trust fund that will pay patients that have mesothelioma from asbestos exposure, and so you can sometimes help your patients out. Mesothelioma is a very difficult cancer to treat. It usually involves the pleura and is very hard for the patients to take care of and do well with. You also can see a lot of adenocarcinoma with asbestosis exposure as well. So all cancers grow two ways. The primary tumor itself gets bigger, but unfortunately, sometimes the cancer cells themselves break loose from the primary tumor and spread to the surrounding areas. They either get in the lymph vessels and spread to the lymph nodes, or they get into the blood vessels and spread systemically. So the way I describe that to my patients is I tell them that if we got a CAT scan in the future, and heaven forbid we found a spot in their lungs or their bones or their liver, they wouldn't have, excuse me, if they found a spot in the bones or their liver, they wouldn't have bone cancer or liver cancer. They would have lung cancer in their bones, lung cancer in their liver. And so it's very confusing for patients to think of that, because many times they'll say, well, my aunt died of breast cancer, lung cancer, and brain cancer. No, unfortunately, their aunt died of breast cancer that spread to the lungs and spread to the brain. Very few patients have more than one cancer. Most patients have one cancer and have metastatic sites that cause the multiple problems that they have. So when you have lung cancer, one of the problems with lung cancer is, remember we talked about this large pulmonary reserve due to the extensive set of blood vessels and the large surface area. So the body has a wonderful job of compensating with problems. And so that's very true in lung cancer. It's also true in pancreatic, for example, where the cancer can be there and start to grow and cause a lot of trouble, but because the body has so much extra reserve, you have no symptoms from it. So it's very unusual to have any early signs or symptoms from lung cancer. And as a result, lung cancers are usually not discovered until they're in advanced stage. And when they have the advanced stage, that makes it very difficult to treat, which we'll talk about in just a second. When they present with signs and symptoms, the signs and symptoms are usually pulmonary. The pulmonary signs and symptoms are usually the local signs we talk about in the next bullet, which is dyspnea, which is shortness of breath, hemoptysis, cough, and sometimes dysphagia from swelling lymph nodes that can block the esophagus. But the systemic ones are also critically important in lung cancer, especially when we treat them, with weight loss being very important. If a patient's lost more than 10% of their weight, it's going to be very difficult for them to get a good response from any kind of treatment we give them, because that 10% weight loss represents the tumor burden that the patient has and the effect that that cancer has already had on that patient to cause them to lose that much weight. Depending on where the cancer is, if it's in the bones or if it's in the pleura, they can have a lot of pain. It's a strange thing with cancer in general, but anytime you have cancer growing in you, you have this a fatigue that's really hard to pinpoint. It's almost like a malaise, and it's because the cancer is growing, and if you can stop the cancer from growing, that malaise will go away and the fatigue will go away. But sometimes you can also have nausea, and you can have neurologic symptoms, especially if you have brain metastases. And we did talk about the paraneoplastic syndromes, especially with small cell lung cancer. They can be hypercalcemia, which is the first symbol we have there, syndrome of inappropriate ADH. You can have spinal cord compression. You can have superior vena cava syndrome, cardiac tamponade, or just a pain syndrome in itself. And all these can be caused by the cancer itself. Now, paraneoplastic syndromes, though, are unique because they aren't caused directly by the tumor, but they happen because the tumor is present. We're not exactly sure why that does what it does, but sometimes you develop these syndromes and there's no obvious easy cause. But if you do have a syndrome of inappropriate ADH in a smoker, you certainly need to look for small cell lung cancer because it could be the cause of that syndrome of inappropriate ADH. Prognosis. Well, this is what we've talked about all along. That lung cancer has a very, very difficult prognosis. If you look at 5-year survival rates, from the most recent thing, it's about a 16% 5-year survival with lung cancer. That's all comers, people that can be operated on and everything. But if you look at when I first started these many years ago treating lung cancer, our survival rate was almost the same at 1 year, because people died very quickly because we couldn't really treat them very successfully. But now with chemotherapy, radiation therapy, and some of the new targeted therapies, the 1-year survival rate in the U.S. is now up to 44%, and the 2-year survival is sometimes as high as 25%. That's still horrible, but for what it used to be is really much better, and it means that palliative treatment of patients with lung cancer can be meaningful now because a significant number of patients can survive and have a reasonable survival, a reasonable quality of life with this disease, and it's getting better all the time. But the survival rates for 5 years are 25% for regional disease, but for advanced disease it's 3.7%. So that's how you get that 16%. And small cell carcinoma is even worse. Small cell carcinoma is really kind of a devil of a cancer because it's very sensitive to chemotherapy. When you treat it with chemotherapy, the cancer almost always, as high as 80% of the time, will almost completely go away. But then within 6 to 18 months it grows back, and it's almost impossible to treat then. So that's particularly cruel for the patient because the patient gets this disastrous diagnosis of lung cancer. They finally get some treatment for it. The treatment works so well, and they have great hopes that they're going to continue to do well. And then within 6 to 18 months, it starts to grow back, and there's not much we can do for it at that time. So small cell lung cancer really is a cruel disease almost because it teases the patient into having this view that they're going to do very well, and then it comes roaring back and takes them away from us. And one of the roles we have, and what we'll talk about later on, is how important it is that we educate patients in things like this, because I always tell patients with small cell that we're going to do great initially, and we're going to try to do as good as we can, but unfortunately this stupid disease has a high rate of growing back rapidly. So let's talk a little bit about molecular testing now, because this is a very important component of lung cancer therapy. And we talked a little bit about this when we talked about the diagnosis, if you recall. We talked about we would send off material for molecular analysis. What are we looking for? Well, we're looking for EGFR mutations. These are tyrosine kinase inhibitors that these are mutations that we can use tyrosine kinase inhibitors on to treat and to make the patients or actually make the cancer stop growing and actually shrink away and stay under control for long periods of time. These EGFR mutations are seen in about 50% of the patients. They're very common in Asian patients. They're more common in women and in never smokers. They're not very common in smokers, and so that means that the TKIs, there are 2 examples of that we've got listed there, erlotinib and gefetinib, which is Tarceva and Iressa. Both of those drugs can be very helpful in women, Asians, and never smokers that have those EGFR mutations. In fact, we use those therapies primarily before we use chemotherapy, and they can have a nice response rate for sometimes up to 2 years and maybe even longer with some of these agents. So it's really very important that you check all your patients for EGFR mutations. But you can often get a clinical sense of it because heavy smokers almost never have these mutations, or if they do have these mutations, they won't respond well to them, because the more you smoke, the more mutations you have in your cancer. And the more mutations you have, the harder it is to use targeted therapy, because targeted therapy by its very nature only attacks one mutation at a time, EGFR mutation or lotinib. But if you have a smoker's lung cancer with multiple mutations, even if you attack the EGFR mutation, the other mutations may well have drivers in them that cause the cancer to continue to grow, even if you stop the growth potential from the EGFR mutation itself. Now, KRAS is very important because if KRAS is mutated, it's another gene in the same cell. It's another gene, excuse me, in the same pathway that causes the cancer to grow, and it's downstream. So if KRAS is mutated, it doesn't matter what you do with EGFR because the pathway's turned on already. So if you have a KRAS mutation, the TKIs, the tyrosine kinase inhibitors, are not helpful. Two other genes that are in that same pathway are the ALK gene and the ROS gene. And if there's rearrangements in those two genes, we have a drug called crizotinib that sometimes can cause them to respond well. The incidence of ALK and ROS rearrangements are about 3%, maybe as high as 5%. So they're very rare, but that's what we look for with our molecular testing. What are some of the risk factors to develop the cancer to begin with? Well, the big one is right there, smoking, smoking, smoking. If you list the top 10 causes of lung cancer, the top 9 are smoking. It really is just such an important contributor to smoking. There was lung cancer before people started smoking extensively, but it was a really pretty rare disease. It was certainly might be in the top 5 of diseases in the late 1800s and the early 1900s, but it became the big dog after people started smoking. Secondhand smoke is an important contributor to this. How much it actually contributes to the development of cancer is still not clear, but we know it does have a positive contribution. And then we had talked about earlier that there are other contributors. We talked a little bit about asbestos before, and radon gas, which is a gas that can be in homes sometimes that come from the ground underneath your home. If you live in a home that has too much radon gas and have that exposure, you have an increased risk of lung cancer. There are certain genetic factors that can happen. If you have underlying COPD from your smoking, that can be a risk factor for developing lung cancer as well. We do have the ability to have prevention and screening for lung cancer, though. And this has really been a very difficult thing for us to put together because you have to first, whenever you have a screening that you're doing in cancer, you have to identify the population you're going to screen. Well, in lung cancer, it's easy. It's heavy smokers. So how do we describe those heavy smokers? Well, they have to have at least 30 pack years of smoking. A pack year is 1 pack per day for 30 years. That's a 30 pack year smoking history. So if you smoke 2 packs a day for 15 years, that's a 30 pack year smoking history. And so if you're between the ages of 55 to 74, studies now show that with low-dose CT scanning, we can pick up lung cancers at a very early and potentially curable stage because they're very small, and we're going to talk about the treatment in just a little bit, but when we talk about the treatment, the only real curative option we have is surgery. And the smaller the lung cancer is, the greater the chances surgery have of curing the disease. So lung cancer screening turns out to be important. It turns out to be worthwhile from a monetary point of view, which is why we always decide about screening, because insurance companies run everything now. But it also turns out from a public health point of view to be a very good way to try to find early lung cancers that we can cure surgically to prevent those poor souls from having the trouble of more advanced disease. So medical management of lung cancer. Now, why do we talk about medical management of lung cancer? Well, we've tried to paint a picture of a lung cancer patient that usually is a smoker, usually has other comorbidities, usually has bad lungs because of their smoking. So when you deal with lung cancer patients, which is 85% of all lung cancer patients are really that scenario, you're dealing with a lot of comorbid conditions. You're dealing with COPD or chronic bronchitis. You're dealing with probable peripheral vascular disease and coronary artery disease from their smoking. They may have diabetes. And so all those things excuse me, are very important in trying to decide how you want to try to treat the patients. Now, the decisions on the medical management itself are dictated by what stage it is, what histology it has. The PS is the performance status that we talked about. And the thing that we always have to remember is the patient has their own right to make their own decision about how they'd like to proceed with treatment. And one of the nuances of good care of lung cancer is being able to talk to patients and help them understand what their options are. Because when people get a diagnosis of cancer, their first knee-jerk reaction is, I want to do everything I possibly can to get better. And that may not be appropriate with lung cancer. It may be appropriate not to have any treatment. It may be appropriate for them to go straight to hospice and get supportive care only, and their quality of life might be much better with that kind of approach. So, unfortunately, as we talked about, most patients are diagnosed at an advanced stage, and they have limited ability to have long-term survival, which we just talked about. And so when they have that, and this is a discussion we have with all our lung cancer patients. For example, if you have a stage 4 lung cancer patient, the discussion we might have with them is, if you have a limited amount of time to be with us because we can't cure this disease, how do you want to spend that time? Do you want to spend that time taking treatment that might get your cancer under control, might get you to feel better longer, might increase your survival, but also might give you side effects and might actually make you feel worse than you do now? Or do you want to just see how things go from this point forward? And that's a very personal decision for everybody involved, because you're not in their shoes, you haven't lived their lives, and you don't know exactly what their outlook is. They may be at the end of their lives. They may have had a wonderful full life and they don't want to go through a lot of hassle with chemotherapy, and they may just want to see things progress as they'll progress. Other people have milestones that they're looking for. I've had a number of patients that have a grandchild. I just want to be around to see my grandchild born. And so, okay, let's do our very best to help you get better, and hopefully we can do better than that so you can be with your grandchild for a long period of time. So those are the very difficult medical management kind of decisions that we have with lung cancer patients. Also, because of the poor outlook, we should always think of research with lung cancer, because we do okay with lung cancer. We do a lot better than we used to, but we're not doing nearly as well as we would like. And research always gives us the option and the hope of something better than we have now. And lung cancer really should be a patient with lung cancer should really be treated by a multidisciplinary team. You should have a surgeon involved, if appropriate. You should certainly have a radiation therapist involved, and the medical oncologist involved, and the palliative care team involved. The palliative care team doesn't necessarily mean that you're going to put them on hospice right away, but the palliative care team can do an excellent job of helping with their symptoms. Let's talk about surgery then. Surgery is our best option for cure. The way this breaks down, though, is because lung cancer is diagnosed generally so late in its natural history, only 30% of newly diagnosed patients are eligible for surgery. But of those 30%, 70% can be cured. So that's where you get your 16 to 20% patients that are cured of lung cancer. 30% only can be operated on, but of those ones that can be operated on, 70% can be cured. So If you have a surgical option, you really want to try to take that surgical option because they really do, it really is your only chance for cure. When you do that surgery, you want to think about lung-sparing surgery as much as possible. We rarely take out entire lungs anymore because remember, these people already usually have significant pulmonary compromise, and to lose an entire lung is very, very difficult to continue to go with. So we usually do lobectomies or wedge resections, and that's called lung-sparing surgery. And we try to use minimally invasive techniques. The video-assisted thoracoscopic surgery is the VATS procedure, where they do very much the same thing they do with gallbladder surgery now. They use the scope, they go in, they can take out a lobe without doing a big incision in the chest, and the recovery time is much better, and they do much better. When you have surgery, one of the things that's very important, and one of the things that differentiates a good medical center from a poor medical center, is whether they do systematic lymphadenectomy, which means evaluate the lymph nodes, because it's very important for prognosis. So for example, many times before surgery takes place, a patient will have a mediastinoscopy or will have an endoscopically directed bronchoscopy ultrasound to try to look at the lymph nodes in the center of the chest, in the mediastinum. Because if those lymph nodes are positive, the chances of being able to cure that patient with surgery are much reduced. And so if you do that mediastinoscopy, or what's called an EBUS, before the surgery, and you find out they have positive nodes, you save them a surgery that can't cure them. So systemic lymphadenectomy is very important, and sampling of the lymph nodes is very important in the staging and in the surgical treatment of lung cancer. Surgery can also be used in a palliative sense sometimes, because you can have isolated resection of isolated metastases. For example, remember the 10% of the patients that presented with a brain met and have a lung cancer, a lot of times what we try to do with those patients is resect the brain met and resect the lung cancer, and there is a reasonable rate, about 20 to 25% of those patients can have long-term survival even though they had a brain metastasis. Sometimes if you have an isolated adrenal metastasis, we can surgically resect that, and that can be very helpful in giving them a chance for long-term disease-free interval. Radiation therapy is the use of radiation to treat the treatment itself. It can be primary therapy, it can be adjuvant therapy, or it can be palliation. It is primary therapy in stage 1 and 2. We usually only use radiation therapy when the patients are not surgical candidates. They meet all the criteria for surgery, but for other reasons. Maybe they have a bad heart, or their kidneys are not good, or whatever. They're not good medical candidates. Well, then radiation can be used to try to treat those early stage lung cancers, and can have a chance for cure. That chance for cure is not as high as it is for surgery, but it is a very real number, and certainly something that should be done. Adjuvant therapy or combined therapy is done many times with radiation as well. For example, stage 3A, the standard treatment for that is to do what we call combined modality, where they go in and radiate and give chemotherapy at the same time, and there is a cure rate from that. It's very low, but it is a possible cure rate, and certainly worthwhile for the patients to try to undergo. And palliation radiation is very important. For example, if you have brain metastases that can't be resected, you can do palliative radiation to the brain metastasis, and that usually will control the brain metastasis for the remainder of that patient's life. It often can be very effective. Sometimes if you have a bone metastasis, you need to radiate that in a palliative way to make sure they don't keep hurting. And that's what we were talking about with the next bullet, with isolated metastasis, especially in bone and brain. Stereotactic ablative radiotherapy of small lesions is possibly curative as well. And this is the idea, it's called SBRT, stereotactic radiation, where they use very high doses that are aimed by computer techniques to be very, very finely tuned at just the tumor itself without hurting the surrounding tissue. And instead of being a full 6 weeks of conventional radiation therapy, this could be 3 or 4 sessions. For example, Monday, Wednesday, and Friday, a very high dose radiation that can be very effective at treating small tumors and sometimes get rid of them completely. And finally, we can do radiofrequency or microwave ablation of the tumor itself, where you take a tiny needle that has a microwave or radiofrequency probe on the end of it, put it into the tumor at the same way you would do the biopsy, and burn that area out. This can also be very effective on isolated metastatic sites, such as in the liver or other areas, for palliative treatment of the patient. Chemotherapy is what we do a lot. It is used as an adjuvant. It's used combined with radiation in stage 3 that we talked about, or in all stage 4 cancers. Now, unfortunately, remember, we said 70% of patients are not surgically treatable when they're first seen. So that means that those 70% are going to see going to see chemotherapy either in combined modality or as a single modality. So chemotherapy turns out to be the major modality we use for most patients with lung cancer. The adjuvant treatment of lung cancer is important, though, because if you have a stage 1 or 2 lung cancer that you can surgically remove, just as in breast cancer, you can give chemotherapy after that and increase their chances of being cured by killing any micrometastatic disease that's left behind. The standard of care for 80%, as I said, the chemotherapy is the standard of care for 80% of the cases because that's the amount of advanced disease we have. The standard right now for first-line treatment is cisplatin and carboplatin doublets. We use drugs like gemcitabine, Taxol, Taxotere, Alimta, which is pemetrexate, as our doublets that go with the carboplatin and the cisplatin. Cisplatin is used when you have a potential chance for cure, for example, in the adjuvant setting. But if you're doing, if you're treating metastatic disease, stage 4 disease, and you're doing it in a palliative manner, we use carboplatin. The reason is because carboplatin has fewer side effects than cisplatin. But that is the standard of therapy and can sometimes be very effective. The treatment for small cell lung cancer is carboplatin VP16. We don't use VP16 very much in non-small cell lung cancer anymore. We already talked about the targeted therapies. We talked about erlotinib, crizotinib. We talked about the TKIs, but we also didn't talk about bevacizumab, which is a vascular endothelial growth factor inhibitor, VEGF inhibitor. And what it does is it blocks the formation of new blood vessels around the tumor. Think of the tumor as a subdivision out in Collierville. That subdivision can't get any bigger unless you can build roads. Well, those roads are the blood vessels. And the tumor can't get any bigger either if it can't build its own blood vessels to grow. And Avastin, which is the trade name for bevacizumab, blocks the formation of those blood vessels and can really help chemotherapy, make the chemotherapy more effective and help control the disease better. So those are some of the targeted therapies we use in treating lung cancer as well. Palliative care is what all of our patients, the majority of our patients will need during their treatment with lung cancer. Now, I could really say all of them because what I mean by palliative care is not just end-of-life and hospice care. I'm talking about supportive care to get them through curative therapy as well as supportive care therapy. But it's an important concept, especially in advanced disease, because what we're trying to do is we're trying to make the quality of their life as good as it can be for as long as it can be. The best way to do that is to treat the disease primarily, but with the idea of trying to help with symptom control, we can make that even better. So palliative care is really symptom management. Now, many times that does end up being at the end of life, but it doesn't have to be just at the end of life. And what we do at the clinic now, as you know, is we've integrated palliative care in very early into our stage 4 lung cancers. So what we do is we monitor side effects and we assess response to therapy. We do that frequently because we do not want to give these medicines that have potential side effects unless there is a response to therapy. We don't want to give the medicines if they're not effective. And one of the important parameters in the treatment of lung cancer is what is your incidence of chemotherapy in the last 15 days of life or in the last 30 days of life? And what do we mean by that? What we mean is we don't want to treat these cancers with medicines that are not helping them, give potential side effects, and can hurt the patient. If the die's cast and you can't help them anymore, you need to stop treating them and think about our next bullet, which is hospice care, because it's such an important consideration in all phases of the treatment of lung cancer. And we talked about that even at the very initial diagnosis. If there's very little chance that the patient might respond, we need to think about hospice care. So let's talk a little bit about the nursing implications. We've talked about this in a general sense all along, but I wanted to just bring this together at the end because I think nurses play such an important role in this, and I think the oncology nurse is really the unsung angel of medical care in general, because you guys deal with, I might deal with the science of the cancer. I might deal with what chemotherapy to give, and I try to give whatever solace I can, but it really is the oncology nurse that delivers the emotional support that the patients need. And in lung cancer, that sometimes is the most important treatment you can have. So some of the things we like for you to think about from a nursing point of view are the patient and family understanding. Understanding their cancer, I think, is critically important. And so you want to make sure they understand the goals of care. We can't cure this disease. We're going to try to get it under control as long as we can. It may get better for a while, but eventually it may stop getting better. You want to work on the patient's coping skills and on the family's coping skills. One of the big things is I don't want my Auntie M to know she has cancer. Well, your Auntie M is going to know she has cancer because she's coming to a cancer clinic and she's getting chemotherapy. So you have to help them cope with that, and you kind of have to help work with the family mechanics. Now, the nuance here is that you can't remake a family. You can't remake relationships, but you can take advantage of the relationships that they already have to try to help the patient overall. And that's the skill of an oncology nurse, is to be able to do those kinds of things. You need to know what your community resources are. What do you have? We have a wonderful care support system in our clinic that can help us with that. What do we have for transportation? What do we have for home care? How do we get this patient taken care of? And the community resources are very important. You want to make sure that they have hope, but you want to make sure it's realistic hope. So our hope for you, sir, is that we can get your cancer under control long enough to see your grandchild born. Our hope for you, ma'am, is that we can make sure that you are as comfortable as possible for as long as you can be. So realistic hope and not false hope is very important for these patients. Anticipatory grieving, you'll see that a lot, and you want to try to help them with that, because they're going to anticipate that their loved one is leaving, or the patient themselves is going to anticipate that they're leaving, and they start grieving right away, which is certainly a very appropriate thing to do. But what I try to keep reminding them, I keep telling them, keep living. Don't start dying yet. Keep living, and we try to get as normal a life as possible. Now, that's kind of a crazy thing to say when you're getting chemotherapy and you feel like crud, but you want to try to be around your loved ones. You want to try to be in your home. You want to try to be in a situation that's as comfortable as it can be as you get closer to the end of your life. With regard to nursing implications for treatment, it's very important that the oncology nurse knows what the side effects are so they can help prevent them and they can monitor them and understand. And then we talked about education, and if they have surgery or if they have some side effects from chemotherapy like radiation burn or something, wound care becomes important, and all the effects of therapy is very important. We need to understand what neutropenia is. Remember, neutropenia is low white count. You need to understand what drugs give you a high risk for neutropenia, what drugs don't. How do you handle neutropenia if you do have it? The targeted therapies are very bad for causing rash and diarrhea, as are some of the chemotherapies. And so you need to know a little bit about the treatment of that as well. Pain and distress is critical, because pain and distress in studies that have been done are highest for lung cancer patients of all cancer patients, because the distress of knowing that you're going to die from this disease, and often, unfortunately, there is pain associated with the lung cancer because it'll spread to the bones or to other areas that can cause pain. So being able to help them with those symptoms as they get close to the end of their life is a critically important part of a nursing implication as well. So, a lot of stuff, talked real fast. what we were trying to do, our last thoughts are, is that this is a terrible disease and it has a catastrophic impact on the patient, the family, and the social milieu of the patient, all their friends, all their church groups, everything. And all too often it has a poor prognosis, which we've talked about, which presents an incredible nursing challenge. But you know, that's the reward of oncology. The reward of oncology, unfortunately, not often enough, is curing the cancer. That's what we want to do, but we don't often get to do that. So the reward of oncology is being able to help these poor souls through this very, very difficult challenge. And that's certainly one of the rewards I get. That's why I enjoy coming to work every day. But it's really a very difficult challenge, and emotionally it can be really tough. Now, I don't want to leave you with the negative thing. I want you to know that lung cancer is getting better. And one of the things I wanted to talk about just in the last couple of minutes is some of the new treatments we have, specifically the checkpoint immune therapy. These drugs are incredible and can be incredibly effective in lung cancer in giving us a breakthrough in the treatment of lung cancer that we've not had in the past. It's not a panacea. We're not necessarily curing more people than we did, but they have less side effects with their treatment, and patients can live longer with good quality of life on these drugs. So, and they're just the beginning, along with the targeted therapy, of how we'll treat cancer in the future. So there's a bright future for lung cancer. It's not here yet, and our everyday dealing with lung cancer patients can still be very difficult, but it can also be very rewarding because we're taking care of patients and doing our best job. Thanks a lot. That's all I have. Good luck with the test. I hope this helps.